how lucky am I to be sitting in the podcast studio with my idol and legend for 30 years, Dr. Richard John Simonsen, BA, BS, DDS, MS, PhD, FACD, FICD, FAAD. I mean, you were the starting dean of AT Still with Jack Dellenberg. Then you went to Midwestern. Then you went to California. Then you went to where you went to school. And so I'm with Dr. Faraj Edher, DDS, Master's in Science, Diplomat of Prosthodontics, and he is the youngest prosthodontist, or youngest specialist, or youngest prosthodontist?
Specialist, as far as I know.
Youngest specialist in North America?
As of 2 years ago.
At age 29? Oh my God, my baby's older than you. And so you went to dental school. You're born and raised in British Vancouver, but you went out to dental school where he was the dean in UAE.
Mm-hmm.
And the name of that school, let me see how, University of Sharjah. Sharjah. Okay, so you went to University of Sharjah College of Dental Medicine. So let me read your bio first, because everyone knows who you are. He's a prosthodontist. He's the founder of the digital. Are you the founder of the Digital Dentistry?
No, I'm the director.
You're the director of the. Okay, I'm sorry. I'm not reading here right. He's the director of the Digital Dentistry Institute, clinical assistant professor, University of British Columbia. He's a specialist in prosthodontics. He received his dental degree from the University of Sharjah College of Dental Medicine, and then continued his master's in craniofacial science and postgraduate special training in prosthodontics at the University of British Columbia. He's a fellow of the Royal College of Dentists in Canada and an active member of the American College of Prosthodontists, Association of Prosthodontists of Canada, and the Canadian Association of Restorative Dentistry and Prosthodontists. He has founded, co-founded, and is actively involved with several international dental associations and has represented Canadian dentists and dental students at multiple international platforms. Dr. Edher is the director of the Digital Dentistry Institute, a global education organization that conducts comprehensive training programs in digital dentistry and implant dentistry. He regularly gives presentations, seminars, and workshops, both locally and globally, on a range of different topics. These topics include generalized and specialized presentations focusing on digital dentistry, implant dentistry, treatment planning, and aesthetic rehabilitation. His current clinical and research interests are focused on the application of digital technology in dentistry, complex implant reconstructions, and aesthetic rehabilitations. In addition to practicing full-time in Vancouver and Coquitlam, and what is that, a suburb of Vancouver?
Yeah.
Which, by the way, is my favorite city in North America.
Me too.
It's just every time. In fact, I think I do the Alaskan cruise a couple of times just because it starts there. Dr. Edher is a clinical assistant professor and guest lecturer at the University of British Columbia and has numerous publications in areas such as digital dentistry and dental implants. And I hope that you add Dentaltown to your list and make us an article someday. But so you're 29. Richard's 129 and I'm 109. It must be very different. This profession must be very different from you, where we started out with rubber base and polyvinyl siloxane and all this stuff like that. And now it's all going digital.
Yeah, it's honestly, for me, it's what I'm most excited about because I feel like I'm at the peak of the revolution of dentistry when it comes to utilizing technology. It's like when implants were introduced, 50 years ago or whenever they were introduced, we knew it was going to change the way we treat our patients. And I think we're at that stage again now. And for me, it's exciting because being at the start of my career, I can kind of jump onto that train and contribute to it and help advance it in a way that, makes a difference.
I feel like Richard and I lived through the first revolution, which was materials revolution. Mm. When we were in school, amalgams, I'm still old school. I still believe that amalgams last 38 years. I mean, it's metal, every ingredient's antibacterial. Hell, it's half mercury. They never put that in a multivitamin. The other half, silver, zinc, copper, tin. The whole thing's antibacterial, and we replaced it with inert plastic. But when Richard and I were in school, it was full gold crowns and amalgams and the new PFM. And then the material revolution, the composites, adhesive dentistry, that's gone full spin. And we saw, I can't believe I lived through the beginning and the extinction of the PFM. And I'd say about 2000, was the beginning of the digital revolution. And now it's 2020. So how does that digital revolution look 20 years into it? What's bleeding edge and what's leading edge? What is still kind of
Yeah.
fantasy and what is there?
Well, whenever I'm in a room talking about digital dentistry, I ask people, how many of you use digital dentistry on a day-to-day basis? And usually, 25-30% of the people will raise their hand. And then as I get deeper into it, we start talking about the fact that digital dentistry pretty much means digital technology in dentistry. So how many of the people in that room use, digital radiographs or use digital filing charts? So I think when we talk digital dentistry, like you said, from around maybe 20 years ago, we started to see the introduction of this technology. It's already integrated in every single practice pretty much in one form or another. But the way that it's really new nowadays is more how it's being implemented and how we actually treat our patients rather than how we market or how we schedule appointments or how we chart or radiographs. We're utilizing it with things like, we're using augmented reality on a day-to-day basis in our practice at least. We're using some version of artificial intelligence. So it's those new applications and being able to merge them with a lot of the traditional old school concepts that are tried and true, that we know work, but being able to do them in a much more predictable way. That to me is the most exciting thing about this digital technology. It's the predictability of it, and it's the ability to communicate so much more effectively. Very similar to what we're doing now, like you're saying, the power of a podcast, right? It's utilizing digital technology to communicate so much more effectively than we could have ever communicated before.
Yeah, because it started out it was a radio wave. And podcast is just a radio, but now it's digital. And just like YouTube, we started out on the TV, 3 channels, and I can't even watch the TV anymore because you have these like 100. You just surf through 100 channels. Like man, I can sit on YouTube and find something in 3 seconds.
Yeah.
Crazy times. Digital dentistry. I'm Irish, so I'm really excited about artificial intelligence because Irish natural intelligence is very, very challenging. So I know that I know when I have my Irish natural intelligence up here that the I'm going to bank on the AI. Is AI coming? Do you see it making an impact on prosthodontics today?
Not so much on prosthodontics yet. It's mostly so there's a lot of research going on. There's a lot of startups looking into using artificial intelligence for example, interpreting radiographs and things like that. But I think its first real application in terms of practicality to everyday practice is it now being integrated in digital impressions or intraoral scanners, right? So some of the newer scanners now have artificial intelligence in them where when you take a study model on a patient, not only are you using a digital impression, but that same software will recommend to you or at least, suggest to you where there's occlusal caries, where there's interproximal caries. And this is very new, but the initial evidence that's coming out is actually showing that it's pretty accurate and sometimes definitely more accurate than our eyes. And some studies are showing that it may be more accurate than a radiograph. So having that ability as a starting point to take a study model and right there and then identify where there might be caries and whether it's incipient or, more progressed, that's a game changer. And we're only going to see more and more of that.
Yeah, I'm I'm really interested in the military. When a submarine goes out on a mission, it's gone for 6 months, and they can't surface because you have a cold or whatever. And so they've developed an amazing AI for you. Just sit down, it knows your age, it knows everything about you. You just tell it your symptoms. But anyway, everything I see on that is they're like 94, 95% right. But when you go into an emergency room, they're not even in the 90s right. And I see they said the biggest bias is like if I'm a female Native American Indian and my doctor's a male Irish guy, just the more apart the patient doctor is, the more errors there are. I've seen. I want you to settle the big prosthodontic deal. AI, it's an object-oriented programming language. What do they call it? Python. So they like reading impressions. They like reading X-rays. They like anything object-oriented. And I've noticed some insurance companies are using it now. They just busted some lady dentist in San Diego who I guess was resubmitting the same X-ray for a root canal to I think it was like $600,000 or something crazy. But anyway, she's looking at 10 years. But a human wouldn't remember that he'd seen that X-ray a dozen times, but AI did. But when I talk to the labs, it's funny how dentists will say, "Well, if you scan the impression, it's so much more accurate." And then I'm old school. I'm still polyether, emper gum. I know I should switch to polyvinyl siloxane, but I'd probably have to go to therapy to do that. I mean, I've been on it since 85. When I was started with emper gum, it was owned by the Germans. Now it's bought by 3M. But every lab tech that I talk to says, sloppy dentist. Sloppy, if you're sloppy with a scanner, you're sloppy with emper gum,
Garbage in, garbage out.
Yeah, garbage in. They always tell me that for their lab and their clients, the sloppy ones, when they switch from whatever, they're still sloppy. So but for the young kids, these dental school deans, this guy in particular, dental school's not cheap. Richard has 6 homes and 4 Jaguars, 3 Porsches, so they want to watch their money. So a chairside milling machine, a CAD CAM, that's $140,000. A CBCT, that's $100,000. A BioLace laser, they can make 3 purchases and double their student loan debt. So when you talk about intraoral scanning, they want to know. Do I really need that, or would it be smarter with $400,000 student loans just to take an emper gum?
Again, it'll depend on a lot of factors. In my opinion, it's for any younger dentist, it's 100% worth the investment. And I'll explain why. So first of all, if we're talking about intraoral scanners to replace PVS or emper gum or whatever you're using traditionally, they're becoming more and more affordable. So with new competitors coming onto the market, we're looking at, so in the past 2 years, an intraoral scanner is now available at a price point that's 30 to 40% less than what it used to be. And that's only going to continue because of competition and because of people getting into the market. So in terms of that, it's less of a barrier to entry.
But this is Dentistry Uncensored, so drop names. I mean...
So for example, the Medit scanner. Right?
The Medit scanner.
Medit scanner. So the Medit scanner came into the market, and it was a big hit for the reason that its price point was around 30% less than the higher end scanners like the 3Shape scanner and the PrimeScan scanner, so CEREC and 3Shape.
So Dentsply Sirona, that's Austria. That's high cost. 3Shape, Copenhagen, Denmark, high cost. Medit is Korean, is it?
Medit is, I believe, Korean, yeah.
And so when you say 30% less, well, give me the numbers. Like.
I'm not sure what it is in the U.S. I know in Canada, so instead of a Trio scanner being around, let's say, 40,000 to purchase, we're talking about something in the range of 27 to 30, something like that.
Okay.
And then there's other scanners too. So the reason I mentioned the Medit is because it's also been shown to be pretty accurate. Whereas there are scanners that are in the $20,000 range, so half the price point, but no one's seen that their accuracy is comparable to those higher end scanners. So what ends up happening, just like with anything else, right? This isn't unique to dentistry. Once you have a competitor that comes into the market at a lower price point, you have to start competing with that. So 3Shape then released a more basic scanner with less features, but at that same price point. So in my opinion,
at the same price point. So you're saying as Medit.
Yeah.
So the 3Shape scanner was more. We're talking Canadian, which really isn't even money. But anyway, is it monopoly money or is it? No, I'm just kidding. But 3Shape, you're saying 3Shape in Canadian, Medit was about 30,000. 3Shape was 40,000.
Something in that range. Yeah.
And so now 3Shape is having a lower cost option.
Yeah.
Of a basic.
Yeah. And that it's going with exactly what you're saying, which is depending on your needs. So if you're just getting into running a practice or purchasing a practice, and you're not ready to make the investment where you need all the features that are involved in a fully functional, full option 3Shape scanner, you could invest in a more basic scanner and then add on certain apps, let's say, to it as you progress and as you start using them more, like smile design and implant planning softwares and things like that. So in terms of an obstacle to entry being the cost, I think that's changing and it's going to continue to change really quickly. But then when you also look at it long term, so most people in my generation and newer dentists plan to be practicing for a long time, and you're not going to be using the same scanner forever. You're going to have to update it. You're going to have to upgrade it. But what you have to also account for is how it affects patients. So I get a lot of patients that come to see me specifically because they've heard that I use technology that's more advanced than any other clinic around us. And it makes a big difference, not just because of the show, but because of the communication, like I said.
Well, that's a great point. What kind of cell phone do you have?
iPhone.
That's an iPhone?
Yeah.
And how old is it?
It's pretty old and broken.
How old would you say it is?
Probably a couple years.
2?
2, yeah.
And how old's your laptop?
A year.
Yeah, that's one thing I don't understand, because like, go to a CBCT, which is $100,000. The patient knows, every time I go to the doctor, that they want a picture, an image, that they send you somewhere else. Everybody sends you somewhere else. But if you bought a $100,000 CBCT, well, as soon as it's paid off, you're like, oh, great, I'll have it for the rest of my life. You're going to want another one in 5 years. Same thing with what you're saying, scanner. Wouldn't the better business model be something like a Netflix or a Spotify, a subscription model?
We're starting to see that. So, for example, with 3D printers. Now, CT scans, I don't think that's an issue, because we've been using CT scanners for so long that the advancements being made aren't necessary for everyone. So, in other words, if I have a functional CBCT, in 5, 7, 10 years, I won't necessarily want a new one unless I really want the new features like facial scanning or things like that. But
because I think it's funny how you said your cell phone was old. Dude, it's 2 years old.
Yeah,
but you call it old.
It's true, yeah.
I mean, but will the intraoral scanners like Meta and 3Shape, do you think those will upgrade more faster than a big CBCT? Is that what you're saying?
Yeah, absolutely. Because they're newer, right? So because they're newer, there's so much more advancement taking place. So the scanner that I had 2 years ago is nowhere nearly as good as the scanners that are on the market today. Whereas the CT scanner that I've had for 2 years is probably just as good as the ones today, because not as much advancements taking place in that field. But the subscription model is interesting because Carbon, have you heard of Carbon printers?
Mm-hmm.
They're pretty high up there when it comes to the best printers in the dental industry. They've more recently introduced a subscription or a lease model, let's say, to purchase it because of the high price point. What we're also seeing for intraoral scanners is labs actually purchasing scanners and giving them to dental offices, sometimes for free. And all they ask for in return is a certain fee added to each lab case you do with them. And the reason they do that is because an intraoral scanner for me as a clinician is an amazing thing in terms of efficiency and communication. But when you talk about a dental lab, that's a whole other world. Like they love this technology.
And tell them why they love it.
Because it makes everything so much more productive for them and cleaner and less people.
Instead of getting an impression, and they don't do that from my school at UMKC, but any of the schools that Richard started, when they send in the impression, there's still that bloody cotton roll on the side with juice coming out of it, and then you got to pay a human to pour it up, then you got to wait, and then you got to do all this stuff where it comes in a scan, and then you have the error stacking. So if I take an impression, say that's 20 microns off, then I pour it up in stone, that's 20 microns off, and then I wax it up and take that off, so you just keep stacking these 20 micron errors, and next thing you know, you have 100 microns. So if it just comes in digital, I don't have my labor, I don't have all these errors. So I can see that for the intraoral scanner, amazing. But for the big $100,000 CBCT, like you're a prosthodontist, if a general dentist working with you wanted to send his patient over for a CBCT, how do you charge for that? Or are you good with that? Or do you not like that? Or
there's different models. In our practice, the way we do it is we don't charge for CBCTs. I mean, if someone comes in specifically just to take a CBCT, we charge something similar to what anyone else would charge, which I think is around $200 or something in that range. And but for any of our existing patients or new patients, we take a CBC because we're an implant-based practice as well. We do a lot of implantology. So we take CT scans at no charge, absolutely no charge whatsoever.
But what if a young kid just came out of school with $400,000 student loans and said, I don't want to buy a $100,000 deal and they're probably only doing a couple implant cases a month. If they just sent them over to your place, would you like that, or would you not like that, or would that be good or bad? Or
I mean, I don't see why we'd be opposed to it. We would definitely be
Yeah.
fine doing that. It's but there are radiology centers available, at least in
Yeah.
Vancouver, right?
Yeah.
So people who don't place enough implants to justify the cost, they send their patients over either to another office, like you said, or they send them over to a radiology center and have the CT scan taken.
Yeah.
But it's pretty much also it's a numbers game too, right? You know how many implants you're expecting to place. You know what the cost associated with sending a patient out is, plus the convenience, and then you know long term whether that makes sense or not for you to have an in-house scanner.
Right. So you like the Medit scanner? Is that what you're using?
No, I use primarily the 3Shape scanner.
The 3Shape.
Yeah.
And what's the pro? Why should she get the 3Shape scanner and throw away the vinyl polysiloxane?
Oh, so I don't think anyone should specifically get a 3Shape scanner. I think people should consider switching to intraoral scanning in general, opposed to a PVS. The reason being, well, accuracy. You mentioned that.
But you said you use the 3Shape.
I use a 3Shape for specific reasons for myself in terms of how we function with it. So let's talk first about the advantage of intraoral scanners versus traditional impressions, and then we can talk about the different scanners themselves. But comparing intraoral scanners to conventional impression materials, number one is accuracy. There's more than enough evidence over the past 6-7 years that shows that when you fabricate restorations using an intraoral scanner and a digital workflow, you end up with better adapted margins, with better fitting restorations in comparison to the traditional workflow. That doesn't mean the traditional workflow is inaccurate. It's clinically acceptable because we've been doing it for hundreds of years and we probably will continue to do it for a long time. But we know that this workflow is as accurate, if not more accurate. So that's number one. Number two is the other point that we mentioned, which is no storage. You don't have to worry about models. Everything is saved on a hard drive or on a server somewhere. Being able to pass on that information to the lab. So I can work with a lab in Germany if I wanted to, right? And they can have my case over there in seconds. Whereas, so for me as a prosthodontist, being able to relay that information to the lab and be able to work with anyone I want, whether it's in my area or outside of my area, have them go through a digital workflow, design a restoration for me, send it back again via email, and then all I have to do is press print or mill and fabricate that. So that sort of communication with the lab is a big deal. But all of those things, patient experience, right? There's a lot of evidence and a lot of studies that have been done, but it's also common sense. Every patient prefers the digital impression over the conventional impression. No one enjoys the goop in the mouth that hardens after 5 minutes. So that makes a difference too. But all of that aside, the main two things that I always say are the biggest advantages of digital technology in dentistry are predictability. So being able to use this technology to predictably get, good results again and again and again. And number two is communication, communicating with my patients, being able to right there on the spot, take a scan and show my patient, okay, you can see the crack on your tooth here. You can see how this restoration has an open margin. Being able to visually communicate things or utilizing things like smile design. And instead of me saying, I'm going to make your two central incisors look better and then trust me, I'm actually showing them these are the issues, these are the challenges that we face, and using this technology, here's how we predict the outcome will look like. We all follow informed consent, and utilizing this technology, in my opinion, today is the closest we can actually get to informed consent because you're able to use visual tools to communicate that information to the patients rather than just verbal, predictions or verbal pictures that we draw. So
when you say you're a full-time prosthodontist, how does that break down into fixed versus removable? I mean, or is it?
I probably do 20%, 15% removable, mostly fixed.
Yeah. So it's mostly fixed.
Yeah.
It just one of the problems I have with fixed is the people who need all these implants, they're not the vegan yoga instructor who's hiking 5 miles every morning. They're always Irish alcoholics, smoking, drinking, and they have perio and they lose all their teeth, and then you put in all this fixed stuff and their behavior doesn't change. They can't clean it. But I get it. So it's just psychological that they don't want something that can snap out to clean.
So for patients that aren't willing to, like you said, if we see that someone, for example, has a certain tendency or a certain habit that has us, believe that they're not going to be able to maintain a fixed restoration in their mouth on implants,
But why
then
did they lose all their teeth in the first place?
so a lot of times it's like you said, well, the number one cause is periodontal disease. Number two cause is caries, right? So both things that are directly related to hygiene and not being able to take care of things. But the comparison that we make when we take a look at things is what's the difference in how they're going to be able to maintain that restoration. So there is the option of just a removable denture. Most people don't enjoy that. Most people don't get the quality of life and, let's say, the mastication function that they want with the removable dentures. So we have the options of utilizing implants for a fixed, completely fixed, or a relatively fixed but also detachable, so something they can remove and clean. Based on most of the studies that are out there, a fixed prosthesis, let's say, that's on implants, that's designed in a cleansable and hygienic way, with a patient that's willing to clean it, and they're going to have to be willing to clean it whether it's removable or fixed. So if it's designed in a hygienic, cleansable way, and a patient's given the tools, so we give every one of our patients a water pick that has a fixed for free. Everything we can do to get them to maintain it and clean it properly. So a patient that where the bridge or hybrid is designed in a way that it's cleansable, and they're given the tools to clean it, and they're willing to actually spend the 5 minutes each morning and each evening to clean it, they'll be able to maintain a fixed prosthesis probably just as well as they would a removable. Because even with a removable, even if you have a bar or locators or whatever it is, you still have to remove the denture, you still have to rinse it off, you still have to clean around the implants. So that sort of time that you spend cleaning, you have to be motivated enough to do, whether it's fixed or removable. And the real issue is with fixed, which is really what's given hybrids and all on fours and those sorts of concepts a bad name, is the fact that a lot of times they're not designed in a way that's cleansable, not designed in a way that helps the patient clean them. And that's a whole other topic, right, as to why that happens.
I would just say that the number one predictor of future behavior is past behavior. So what led up to them losing all their teeth, they're not going to, they're going to change. But the thing that they should take note from is that when you go to other surgeons who are giving artificial knee, artificial hip, I think it's amazing how they come into the office all excited and say, yeah, my doctor, he said it went real good. He said I should get at least 5 years out of this. I thought, damn, you spent $50,000 on 2 knees, and satisfaction equals perception minus expectations. And he already set the bar so low, 5 years. I mean, hell, he'll probably warranty it 5 years. Whereas so many dentists, they never, they don't drop the price, and they don't drop the longevity. And so everything we know on case presentation, if the doctor doesn't say the price, looking at the eye and say, and we can do this whole thing for $20,000. When the doctor says that with confidence, then when the person comes in to do the business arrangement, it goes through. But when they sit there and ask all these open questions like, well, would you like to have it done nice and perfect and last forever and all this stuff? Well, how much is it? Oh, well, I'll let Susie come in. She's thinking, damn, you can't even say the number. This is a game. But when you look him in the eyes and you drop the price, Omar Reed taught me that. And I guess his funeral's next Saturday, right? Yeah, his funeral is the 29th at 11. And but he taught me that. You got to look him in the eye and drop the price. But the other thing you got to do is to increase satisfaction minus perception of what happened minus expectations, you have to lower their expectations to raise their satisfaction. So, you do it with pain. You say, when this after I do a root canal, I say, when this anesthetic wears off, I hope you have a pistol because you're probably going to want to shoot yourself. I mean, this is going to be really, really bad. And they're just like, you set it to where they want to shoot themselves. Then they always come in and say, they beat that. They come in, they're all excited. And when you say it's only going to last 5 years, I got patients all the time to say, yeah, you told me it was going to last 5 years. That was 20 years ago. But where you get sued is when you say, it'll last forever.
Yeah.
And then it fails after 15. So you gotta lower expectations. You gotta look them in the eyes and say the price and how long it's going to last. You can't delegate that out to the person who's not doing the procedure. So in prosthodontics, I want you to give a letter grade. So we treat three diseases: perio, cario, and occlusal. How would you say the dentist in Canada and the United States and my gosh, how many countries? And you were in UAE for what, 4 years?
6 years, yeah.
6 years. So what letter grade would you give your community, British Vancouver or dentistry in general, on caries, perio, and occlusion of understanding, diagnosing,
Yeah.
and treating the disease?
I mean, caries is that's a question to think because it depends on how you want to grade them, right? But I would say in general, as a community, myself included, really, and our profession as a whole, we understand Cariology. We understand the biology behind it. We understand everything related to it. We have pretty good guidelines as to how to treat it, so we understand Cariology as a profession. Periodontology, we also have a very thorough understanding of. That's probably the most researched part of dentistry, right, in terms of which bacteria cause that sort of thing and so on. When we compare Cariology to periodontology, I'd say there's probably less of an understanding when it comes to periodontitis and how to treat it, just because of the fact that there's a lot more variables involved in periodontitis and periodontal disease. So there's a lot more options as to what you can do. There's a lot more causes as to what possibly led to this. So when you have multiple different opinions, you're more likely going to have a little more confusion when it comes to that. And then what takes it to a whole other level is occlusion, right? Because with occlusion, most of what we know about occlusion and TMJ and TMD are theories, right? There's very little actual scientific evidence and protocols about. We have basic guidelines. We know we want contact distributed equally. We know we want mutually protected occlusion. Those are things that we have evidence for and we agree on. But then when it comes to how does occlusion actually affect joint disease, or how do you deal with certain occlusal factors that aren't ideal, those are all theories, right?
So again, what do we know and what's theory? What do you say there's science for?
So what we know is how things should be to have a healthy occlusal scheme, to have healthy teeth, to have healthy joints. We know what the ideal is. When it comes to anything outside of the ideal, so when it comes to, for example, even if we talk dentures, so the most basic form of, let's say, prosthodontics, which everything is based off of, so dentures, what sort of occlusion do you want your dentures built into?
0 degree.
0 degree bilaterally balanced, right? That's what we're all taught. If you actually look at the science, there's zero evidence that actually shows that bilaterally balanced in comparison to canine guidance actually does better when it comes to function, actually does better when it comes to retention. The evidence that's out there actually shows that there's no statistically significant difference. So when it comes to occlusion, and that's why you have godfathers of occlusion, right? You have names that are very well known in occlusion because they took the time to see all the information we have.
And who are those biggest names, would you say? Who you say is the most weighted name in occlusion?
Well, I'd say today probably, I would say, at least on my end, based on my education, Dawson's a really big name.
Oh, I would have said Richard before. I would have said Richard first.
If you asked about Cariology, I would have mentioned his name first.
Pete Dawson.
And your buddy in Cariology, he and no.
Yeah.
You two, are you two like the godfathers of...
No.
Well,
he might be.
And you too. You're a humble man. So you'd say Peter Dawson, number one.
Yeah.
Who would you say number two?
For me, Alan Hannam. He's a professor at the University of British Columbia. He was on my committee for my because I did my research for 3 years on digital occlusion. So how does this all apply in the virtual world when we take a look at the bite and things like that? So Alan Hannam's also a very knowledgeable person when it comes to the history of occlusion, the history of TMJ and TMD, and how it applies in today's world and using today's technologies.
But he's only got a BDS and a PhD and an FDSRC. Don't you have anyone with more qualifications? And he's only a professor. So you'd say Dawson and Alan G. Hannam. Hannam.
Yeah.
Okay. Who else?
I don't know. Those are the two that I would consider my go-tos
Well,
for
the reason
occlusion.
I was going to get at it, and I can't really ask this because Richard's sitting right there, but how come when they come out of dental school, they all claim they're confused with occlusion? They don't say that about cario. or perio,
Yeah.
right?
So let me tell
But they
you,
all seem to be confused about occlusion. Is that because it's just so much unknown?
I went through pros training, right? So if anyone's supposed to learn about occlusion, it's prosthodontists because we focus on complex restorations. And we had intensive training because Alan Hannum's at UBC, so he took on the occlusion program. So the more and more you delve into occlusion, the more and more you realize we don't actually know. As a profession, we don't know the answers to the questions. And that's why people are confused, because you give them theories, but if you give someone a theory without actually being able to explain it thoroughly in a way that they understand, they're going to be confused by it. And the fact of the matter is, a lot of those theories aren't backed by hard evidence. So they are just theories, they are just assumptions. And it's so variable. That's the thing. So we know that even patients, right? There are some patients whose perception is so sensitive to occlusion that their perception is more sensitive than a piece of shim stock, which is around 8 microns thick. They can feel something that you can't even detect with shim stock. And there's other patients where you look at them and they're like, my bite feels fine. And then you look at it and there's a 3 millimeter open bite because of such a high contact. So it's such a range of sensitivity amongst patients. And that also makes a big difference, right? Because depending on your patient, you're going to have to delve deeper and deeper into occlusion to get it refined to a point where it's clinically acceptable for that patient.
And by the way, I'm gonna keep answering this on the air, but a lot of people say, why did I put a doctor in front of a name when you put DDS? They're telling me for English and phonetics, and it's always some bizarre narcissist. It's like, okay, when you say UBC, what are the Americans gonna think?
What are they going to think?
Yeah.
UBC, University of British Columbia.
Right, but like Canada into a CA, California into a CA. When people say they went to UBC, I mean they might be thinking of Buffalo, they might be thinking of Birmingham, all these things like that. But in the Middle Eastern world, I love how they say. You can tell by the pronoun if it's a man or a woman. They do it in Portugal too. They go DR is a male, DRA is a female. But the reason I'm not doing it for the grammar English Nazis in America. I'm trying to make it so that when dentists around the world see a name, they'll know it's a doctor. They don't know all the alphabet soup behind it. Like the English and the Canadians, like you have behind Hannum's name FDSRCS. I mean. Who knows what that means? You know what I mean? I am asking specifically about this occlusion deal because money's the answer. What's the question? Some occlusion protocols need tech scan machines, $35,000 machines, things like that. You're a prosthodontist. Do you you talking about digital scanners? You're talking about CBCT. Do you have occlusal machines like that? I mean, do you have a tech scan?
Yeah, I've used a T-scan. I've used it. It's a really good tool for, especially when you do full mouth rehabs, whether it's on implants or teeth, and you want to get a sense of where you're at. Patient feels like there's something off. It kind of tells you, it points you in the right direction. The problem with the T-scan, though, is two things. One, it's not specific anatomically. So it'll tell you somewhere on the right posterior there's a high contact, but it won't tell you anatomically, morphologically where that is. So it points you in the right direction. The other thing is that the T-scan is 100 microns thick, approximately, which means that that thickness is going to affect what it is that you're measuring.
If someone came out of school and they, when you come out of school, the first thing you need to do is, you need like football, you need to learn your basic tackle, your basic block, your basic pass, your basic catch. They need to go in there and do some crowns, some simple endo, learn patient skills. But as they start to morph from one tooth dentistry to quadrant dentistry to full arch dentistry, and they wanted help on their occlusion, what would be the lowest hanging fruit?
So here's a good tip for once you get into more comprehensive dentistry. The best way, in my opinion, the gold standard of checking occlusion is to take your bite registration material, so any sort of PVS that's used for bite reg, and take a bite record of the full arch, and then put it up against a window or a light box, so transillumination. That's a very accurate way. That's considered in at least research, it's considered the gold standard of occlusion. And it's very fast, it's very practical, it's cheap to do, right? And it saves you a lot of time rather than going with articulating paper, which we know is not accurate depending on the material you're testing it on. but a bite registration, you put it up against a window or a light box, and then you can see where the perforations are, and you can see where the light areas of contact are, based on the thickness of the material and the amount of light that you're seeing go through it. Plus, the nice thing about that technique is it actually identifies a landmark for you. So you see that perforation's on the distal aspect of my second premolar. So I know that that's where I'm going to go and make my adjustment.
Just to be honest, keeping it honest here on Dentistry Uncensored, when you go to Alan G. Hannon's website, it says right there, UBC Faculty of Dentistry, Noble Biocare Oral Health Center. Does that, I mean, what is one to make of that? Is it still, obviously Noble Biocare funded it? Is it hard to stay?
No, that's the name of the dental clinic at the University of British Columbia.
Right.
So I'm assuming when it was set up, it was funded or sponsored by Nobel Biocare, and that's why they're on the name.
So, Richard, you've been on, is this your 5th dental school that you're working on now?
Something like that.
AT Still, Midwestern.
Sure. Well, I was with other universities before AT Still, but these, as far as starting them up, yes, it'll be the 4th, I think.
So I remember when Ben Johnson would go around. I remember as I was in University of Memphis, when he set up the endo program, he bankrolled the whole thing, as Tulsa, and other endo companies were up in arms, So what do you think about a dental company like Noble Biocare sponsoring a dental
Well,
school?
I remember when that happened, and I was with a different school at the time, and everybody was jealous that UBC got $5 million or whatever it was to fund this particular project. As long as it's hands-off in terms of the scientific expectations and the clinical expectations, you obviously expect that they will want to have their products used there. As long as the faculty are free to talk about other products, I don't have a problem with that. Everybody knows when you see that name that there's going to be some influence from that company.
Does it bother you?
No. Because having been at UBC, I know that we utilize multiple implant systems. So it's not like we only utilize Nobel Biocare system. We utilize multiple implant systems. Like you were saying, there's no direct influence into the actual didactic aspect of the education. It's one of the 3 systems that we utilize, and to me, it's
well, it's a good segue into the question because the kids all say that implant training, they feel like they need to pick the implant first because if you're out in Parsons, Kansas, and it's all manufacturer driven, and you run an institute. So is your institute manufacturer driven? Is it more agnostic driven? And what would you say to a kid who wants to start learning implants, but she sees that where she lives, all the CE is like from BioHorizons or something, or that was bought by Shine or Noble Biocare or whatever. So how do you separate the that? How could you make her help her make a good decision on where to start learning implant training?
Well, you mentioned it. So there's a difference from when you go to any institute you go to, whether it's a university or a private institute that's providing education, is going to be backed by corporate partners, right? Because they provide the tools that you use, they provide the materials that you use, or even if you're paying for them, you're choosing a system to have them practice on, because you're not gonna run a, let's say a 9-day module and teach people 3-4 different systems. It'll just confuse them. So you'll end up having to choose one system. There's a difference though from going to a education program that's run by a company rather than a educational program that's run by an educational institute or a university that's supported by a company. That's where I think the major difference is. And that's actually one of the reasons why I was very excited to get involved with an educational institute, because whether it's with implantology, a lot of the education we get in implant dentistry is company driven, and that's where I think it's a problem, and that's something that when we run our educational institute, we pay a lot of attention to make sure that is not the case. So in other words, on our faculty, so we have around 25 faculty members at DDI, the Digital Dentistry Institute.
Wow, and 25 faculty?
Yeah, and they range from...
And what is the website for that?
DDIdental.com.
DDIdental.com.
And so those faculty range from They're all across Canada and the U.S. They range from, general dentists to periodontists to prosthodontists to maxillofacial surgeons to dental technicians to denturists. So we have a really comprehensive team. And when we come in and put a curriculum together, whether it's for our implant programs or our digital programs, we make sure to include all the different perspectives. Whether someone uses, Nobel Biocare or uses Straumann or uses Zimmer, whatever it is, we include the actual principles involved in allowing someone to treat their patient in a certain way that's evidence-based, that's driven by experience, that's driven by science. And then after that, we choose a corporate partner that's first of all going to support our vision of being able to provide quality education. And we also choose a corporate partner that we believe in, or at least we have a consensus that they're going to provide a certain quality for our participants. But this applies to the implant programs, but it applies even more to the digital programs, because we do the same thing with the digital programs, right? We've got to choose an intraoral scanner to train them on. We have to choose one, but that doesn't mean
drop the names. Who did you pick?
We're partnered with 3Shape.
Okay, 3Shape.
Yeah, and we're partnered with Nobel Biocare for our implant programs. So for implants, Nobel Biocare is a partner.
You did that whole high-cost Scandinavian thing. You did Denmark, you did Austria, you did. Okay, so you like Nobel Biocare. So why did you pick 3Shape and Nobel Biocare?
Because first of all, like I said, we have 25 faculty. When we looked at what we have the most experience with, and what we as a consensus think is, let's say, leading edge, we agreed that those two companies would provide us with, first of all, the support, and second of all, the innovation to allow us to continue to teach our participants at the standard that we wanted to provide. But the point that I was trying to make was, regardless of whether we're using 3Shape or Nobel Biocare, our goal is that when a participant leaves after a 3-day program with us, they're able to go to any scanning system, purchase that scanner, and utilize it based on just fundamental guidelines and education that they've received that's not specific to, one company or another. And it's the same thing with implant dentistry. If you know the guidelines and principles of implant dentistry, whether you place Nobel implants or any other implant system, it's the same fundamentals. It's just a matter of understanding the armamentarium, understanding the drilling protocols, and that's something that a company can provide you with. That's information that a company sales rep can provide you with.
And tell us about your journey. How did you on DDI, stands for Digital Dentistry Institute. I love the implant thing, and I was really honored to get you on here because dentistry it's an old profession. I mean, today was today's the birthday of Galileo. 456 years ago he was born, so you got to say something about loops, or come on, it's Galileo's birthday. If you don't say something for his birthday, but Pierre Fissure, G.V. Black, it's a 200-year-old deal. But when you look around the world, cleanings, exams, X-rays, fillings, it's been growing 1.5% to 3.5% a year. My whole 30 years I've been in it, the only double-digit growth is in clear aligners and implants. And I know what they're chewing on, as waiting for you to get to on the scanner, was if they get iTero for a digital scanner, that's on their clear aligner deal, because Align Technology, which owns Invisalign, owns iTero. So a lot of the young dentists are really excited about clear aligners, and the smart ones are looking at Smiles Direct Club as a how did they lower their costs? I mean, when Southwest Airlines started lowering their costs, all the other airlines took note. They quit doing meals. It was most of their lowering costs was just direct instead of the hub and spoke. So that was a whole cost reduction. And I've already seen the really smart ones, orthodontists, looking at this and saying, well, I don't have to see you every month. Those guys for $2,500, they see you one time and give you 14 trays. So why don't we do that? And then satisfaction equals perception minus expectations. By the way, if you need to come in and talk to me, it's drop a Benjamin at the door. It's $100. Just come in, drop $100, and you get to see the orthodontist and all that. So back to the scanners. You're with 3Shape. What if they were kind of hybrid, clear aligners, implantology? What do you think of the iTero scanner?
I think it's a great scanner. I've used the iTero scanner, so it's definitely up there when it comes to accuracy, precision. I tell people, if you do Invisalign, iTero makes a lot of sense. right? Just because of what you mentioned. So the workflow's a lot smoother. It's integrated. It makes a lot of sense for me, for example, because I use a lot of I use 3Shape Smile Design software. Our lab, we have an fully digital in-house lab. They use 3Shape software. For us, it makes sense to keep it within the 3Shape workflow. So it's very specific to your overall workflow, what it is that you want to get out of the scanner. If it's just scanning, any scanner scans, and as long as you know that its accuracy is within the ranges that we accept, then it works. It's a matter of what are the other features that the scanner provides that fit into your ecosystem, that your staff is comfortable with.
But they're not open because iTero and 3Shape
They're all open now. So
they sued their way to openness.
So every scanner on the market today, at least based on my understanding, is now open. They all allow you to export an STL file. The last to do that was CEREC, right? They were notoriously known for being a closed system, Sirona, because they had the in-house milling machine that you would purchase, and they still do. But they realized that things are moving in a very different way. That was a limitation to a lot of people to purchase their software because no one wants to, or less people want to commit now to buying a scanner and a milling machine. They might be ready for a scanner. And if you're closed, then that's a limitation for your business. So
I think the data is driven that chairside milling is not working because were you showing me the time?
No. I was just writing down some grammatical issue I had with.
With me?
Well, Richard, it's safe to say that, when Röntgen discovered the radiograph, dentists didn't notice it until the first dental insurance popped up for the Longshoremen's Club. It was right after World War II. It was about 1947, 1948. Our government's best idea was to have price wages. So freeze. So, it's one of those stupid things where they do it all the time. They'll say, oh, New York, the rent's too high, so we're going to freeze rent. Okay, so then no one builds a new apartment complex for 10 years, and, how's that going to work out? And so the government said after World War II, price freezes, wage freezes. Nobody's getting a raise. They froze all wages after the war. So that's when they came back, and the unions, and they're muscle, and they're aggressive, and they argued, and they said, okay, well, then give us dental benefits. And they could have picked anything. They could have picked housing, clothing, cars, gas, but they picked dental. And when you look at this, when they started the dental benefits, they covered x-rays 100%. Oh, all of a sudden, Röntgen's like the newest guy. Röntgen's like my neighbor, and the domino effect of buying an x-ray machine just went clear across America. And so I don't care what anybody says about radiology. All historical evidence shows that when you go around the world and you go back in time, when insurance doesn't pay 100%, it's amazing how many less x-rays MDs and dentists need. But that chairside milling, come on, it's been 30 years. They didn't even get to 15%. So, when you take about intraoral cameras, in fact, would you say intraoral scanning has passed chairside milling? Chairside milling, most of the hardcore data I see is only like 12%. I'm being generous, rounding it up to 15%. But do you think intraoral scanners has already passed chairside milling?
I think so in terms of popularity and being in more clinics, absolutely. Yeah. So chairside.
So chairside milling, it didn't work.
It works for some clinics, right?
But when 85% don't do it, come on, my homies, they all got 8 years of college. Only in Phoenix, if you know the difference between a cosine and a tangent, you're a dentist, a physician. They're smart people. And when 85% of my homies with, study calculus and physics and geometry and all that stuff, when 85% say no, I'll pass, that's damn significant.
No, for sure. I think so. For our practice, we have a group practice. We have around 6 to 7, because one's retiring, on the verge of retiring, specialists, prosthodontists and periodontists. And in our practice, we have a lab. So, for example, if you have a really good relationship with a lab, or you have an in-house lab, or you have a lab in your building or close by, it doesn't make sense to have a chairside scanner, right? Because you can delegate that to the lab. You can take the scan, send it to them, have an agreement with them that, on this day, patient's coming in, I want my restoration back the same day, and you can still provide the same day service, because that's the whole point of a chairside milling machine. It's being able to provide same day dentistry.
Which I'm gonna call baloney on. I worked 3 days last week. I work I work Tuesday again. for 32 years, when I tell someone, "Oh yeah, your tooth broke, you need a crown," their only question is, "How much is it going to cost? Will my insurance pay? Is it going to hurt? What's it going to look like?" I mean, someone says, "Well, I'll do it if I have it same day." I mean, that's like a once every other year, and then because you don't abuse it, you call your lab guy, and he's like, "Yeah, I'll absolutely do it because you don't abuse it." But Richard, I mean, come on, when you're advising dental schools, what's your advice on chairside milling when you know that the graduates from half a dozen schools you worked with, 85% of the graduates don't have it?
Well, it's a huge problem in dental education, what to teach because of what's out there and what's coming. It's a difficult issue. As far as chairside milling, I'm going to defer to the specialist. But we are in the process of setting up a new dental school in California.
Seventh school.
Yes.
So they got UP, UCSF, they got Loma Linda, they got UCLA, USC.
And Western.
And then they got Roseland.
No, that's in Utah. Western. Western is in...
What city is that?
California. Pomona. Yeah.
I lecture there in a week or two.
There you go.
So now they're going to put one in Sacramento.
They are.
And what do you think of that?
Well, I think it's a great location because the whole Central Valley there has a need for a dental school that will train people from that area to stay in that area, hopefully.
And I assume it'll be a DMD school since the last 7
Yes.
were all DMD. I've been told there'll never be a DDS one again.
Probably not.
So if that's the deal, I think they need to, what we were talking about earlier, the initials after your name, I think it's very rude to the American consumer because they see a difference in a DO and an MD, and they're always asking me, what's the difference in a DDS and a DMD? And I tell them the truth. I say a DDS is a real doctor, and a DMD is not. No, I can prove it.
Well, I'm a DDS too, but...
I can prove it because if you go to Microsoft Outlook and you put Howard Ferran DDS, it recognizes the diploma and it puts it in Ferran, Howard. But if I put DMD, now it puts in my last name as DMD, Howard Ferran. So if Microsoft, if Bill Gates' shitty software doesn't recognize your degree, I think it's safe to say it's not a real degree. But don't you think that's confusing too?
Well, yeah, but dentistry is really a branch of medicine. Let's face it, it's a specialty of medicine. And why not therefore link the degree to medicine?
I completely agree. And the reason I like is because when you're in the Soviet Union and you have an injury and eye-hand coordination, whatever, well, you're an MD, you're a stomatologist, you can go back to your med school, do a rotation in dermatology and jump ship. In America, you're a dentist, you lose one eye or one hand or whatever, you can't physically do dentistry, they're going to put you all the way back to dental kindergarten to start another career. And I think that it's a lot better. The 4 years undergrad the same, first 2 years of med school the same, and then after med school, if you want to do dermatology, ophthalmology, stomatology, whatever. But I like the fluidity of jumping back and forth. And I also think it'd be a better entrance. Like if you came here to the United States and you're a dentist from when I got here in Phoenix, this poor lady, she fled Nazi Germany. And she came here, and they didn't recognize her dental degree from Germany. And I get it; I wouldn't either. I mean, this is home of Chrysler, not stupid Mercedes-Benz or Volvo or Porsche or those guys. How would they know how to do dentistry making cars like that? And but I thought it was they didn't recognize her degree, and she was already married and kids and broke. And when I met her, she's about 85. She says, it was the best thing that ever happened to me because she goes, when I heard that, she goes, I just cried. I cried and I cried and I went and got a lawyer. He told me there's nothing you can do. It's a restrictive grade. But what it forced me to do is she had to open up a dental office and could do the dentistry. So by the time I met her, so what was the war? It was over 45 and I got out in 87. So those years later, she had a north, south, east, west. She had a limo. She had a driver and she just drive around checking. She goes, by them taking my hands away, I had to do the business. And she says, my hands would have faded away 20 years ago. But I'm 85. She goes, I can't even drive. I got a driver. But she's driving. I mean, she was probably the richest dentist I knew, other than back. You were here when it was Mort Copenhaver?
No.
Did you ever meet Mort?
No.
Remember he lived on the castle on the side? He started.
Oh, I know the castle.
Denta Health.
Yeah.
Remember Denta Health?
Yeah.
You never met him?
No. Well, I've only been in the Phoenix area since 2001.
And then you were in Minnesota before that?
University of Minnesota, Oma Reed's alma mater.
Yeah, and I go there all the time because my oldest sister is a cloistered Carmelite monk in Lake Elmo.
Ah,
Do you know where Lake Elmo is?
sure do.
So I'd have to fly in there and go do 4 hours and 1 minute at Patterson, 3M, or Minnesota, or Mayo Clinic to make it a business trip. But yeah, I think the Russians do a better deal. But chairside milling, that was the question. My question is, she's asking. She's 25. She's got $400,000 student loans. Do you think she should buy a $135,000 Sirona chairside milling to be a high-end dentist like you?
I don't do chairside milling. I don't do same-day dentistry myself. But unless that's your goal, unless that's your business plan, is to provide that service and market that service, because there's people who build out their practice based off of that, then the answer is no.
But do you really see it? Do you really? I mean, can you give me a name of a dentist who's just like all that in a bag of chips from same-day dentistry?
I have his face in my mind, but I don't remember his name. He's based, I think, in New York.
Yeah, well, New York's the largest city in the United States.
People fly into New York specifically, to see him, not just because they want it same day, obviously, because why would they fly for same day dentistry? But he's taken it to a point where he can do same day dentistry to a certain quality that is superb. But to answer your question, I don't think it's if I were to categorize the technologies you could invest in starting out, a milling machine would not be on the top three.
I like the way you're going. So tell me the top three.
Intraoral scanner.
Okay, intraoral scanner,
Yeah.
and I'm going to say 3Shape because that's what you use. I mean, you said Medit was a better, lower
Medit's
price.
a good one. Like I said, Itero's a good one if you plan on utilizing Invisalign. Prime Scan is a very good scanner. That's Cerex new scanner, Sirona.
Okay.
Those are probably the top four in my
You
opinion.
can't say Sirona because he's married now. He married Dentsply.
And, Dentsply Sirona.
Dentsply Sirona. And how do you think that marriage is going with new products?
It's interesting because they've been able to I'm sure there's more integration to come. But the fact that they've been able to integrate their, Cerec branch to speak with, for example, Simplant, to speak with Atlantis. So they have a variety of different services. And if they're able to integrate them in a way that's practical to use, then I think that's a very powerful thing.
Okay, so first was intraoral scanner.
Yeah.
And you recommended 3Shape.
Yeah.
And you gave us some other names. Okay, so what would be next?
Next would be, I would say, if you're going to focus on implant dentistry in your practice, and that's an if, so it's not if you're placing a couple implants a month, but if you plan on doing it day to day, a CBCT is definitely worth the investment.
And name brands?
I honestly don't think that at this stage, given how far they've come, that there's a difference. I mean, you take a look at a few things. Take a look at the field of view and make sure that it fits what you're doing. So, for example, if you're using a CBCT for endodontic purposes, you need something with a small field of view. If you're doing more comprehensive cases, you'll want a larger field of view. Take a look at the resolution of that scanner, and then focusing on those 2 points, see which one has the most radiation that's applied to the patient. That's how I would judge a CBCT scanner, plus see how it integrates with other systems that you have. But I mean, so we have a Cavo scanner. It's from Cavo.
Scanner?
Yeah. So, it's an ICAT scanner.
So what do you sorry to digress. So what do you it's funny how we live that because you're mentioning Sirona. So when I got out of school, Siemens was like the largest holding company in Europe, kind of like Johnson & Johnson and Gillette and all those kind of things. And some CEO decided they were overweighted in healthcare, so they spun off Sirona. But the building was still there in Austria. It didn't move across the street. It's the same people. You see it all the time. And now we have Danaher, which just took their entire dental division and said, yeah, we're just going to spin it all off and call it Invista because you just mentioned Cavo.
Well, Nobel Biocare, right?
Yeah, and Noble Biocare, and they own Implants Direct. But I just want to tell you, this is what I saw with Sirona. I mean, imagine if your mom didn't love you. And, I mean, can you imagine that? I had dinner with my mother last night. I couldn't imagine that. And when Siemens spun off Cavo, the Austrians were like, yeah, they were all clapping, and they were free, and the parents were gone, and they started this whole storm. And I see the same thing at Danaher. No one will come on the podcast. I've tried to get the CEO to come on, and no luck yet. But basically, my friends that have been in those companies forever, they're like, hey, they don't want us. Great. There goes all your regulation. So now it's going to be a bunch of free guys to go innovate. So if they pull a Sirona, I'm looking for exciting things from Invista.
Who do you think they'd go with?
What do you mean?
Like, what do you mean by pull a Sirona?
Well, Danaher owned. Here, let me pull it up. What is his name? Amir. Yeah, it's Amir. How would you say that? Ogday.
Sounds right to me.
So Danaher owned Gendex, Ormco, No Biocare, Cavo Kerr, Implants Direct, Cybron Dental, all this stuff like that, Oroscoptic, and Danaher said we don't want dental anymore. So they packaged that all up and sold it to Wall Street and guaranteed the stock price for a little while or whatever, and they're all past all that. And so now Amir is the president and CEO of, and I love the name Invista, but basically it's just like Siemens saying we didn't want to get in dentistry, and they spun off Sirona. And so I think when they're spun off and you don't have a mommy or daddy it's all kinds of bureaucracy and regulation, and if you're going to try to come out with a feature, you got to show that, well, if we're going to give you $1 retained earnings, we need our dollar back in a year with this much, and I think they're free. And whenever I've seen this, a bunch of projects that have been killed by bureaucracy because they want to give another penny per stock to Wall Street. I've always seen them get really excited and do a lot of great things. I mean, it's mainly Siemens, but I think Invista. I mean, those are great companies. Mm-hmm. I mean, gosh, Lord, Ormco, Noble Biocare. I mean, those are so many great companies. So I'm on so many tangents over from this podcast. I don't even know what we're talking about right now, but so back to the CBT scanner. Any name brands though?
Like I said, I think it's more the features and the name brands. I can tell you what we use, which is the Cable Kerr iCat scanner. Yeah.
And you use the iCat scanner, and I use Caristream because I was on SoftDent for 30 years until I switched to Open Dental. And there was a Caristream. It was owned by Kodak, so I have the Caristream. Do you like that one?
Yeah.
Good. Okay, so Intraoral scanner, CBCT. What's next?
I would say a 3D printer.
Really?
Yeah.
Wow. And tell us more. A 3D printer.
In my humble opinion, 3D printing will overtake.
No one's humble at 29. You're young, you're hot, you're healthy. No, you get humble at me and Richard's age. You're not humble at 29. But anyway, a 3D printer.
Yeah, because of the fact that 3D printing will overtake milling. That's just common sense.
And it's common sense because, like, say you're going to do a gold crown, you'd have a big block of gold,
yeah.
You'd to shave it all.
I mean, we do mill gold, and then we gather it all up and melt it again and reuse it. So it's possible to use without wasting the material. But if you're talking about things like zirconia or whatever it is, first of all, a 3D printer can do a lot more complex designs than a milling machine can ever do because it's limited by, how many axes you're using. You're using certain tools and equipment, spurs to subtract. Whereas with an additive technique, which is 3D printing, you can design really complex structures. And again, sometimes I feel like we in dentistry don't think of the fact that a lot of this comes from other industries. So this is something that we've seen in so many other industries where they've really moved towards additive manufacturing with 3D printing.
So if that's additive manufacturing, what would you call that?
Milling is subtractive.
Milling and subtractive?
Milling is subtractive technology, which means you're removing material to create something. 3D printing is additive technology because you're adding either layer by layer or adding particle by particle to 3D print an object. So 3D printing is, you can do a lot more complex things than you can with the milling machine. It saves a lot of material. And it's the only barrier to entry has been cost. It's been very, very expensive to get a 3D printer, but that's no longer the case, right?
So name brands.
I mean, Formlabs 2 is probably the most popular 3D printer that there is in dentistry right now. And
Formlabs 2?
Formlabs, well, they actually just released a couple weeks ago or something recent, because Formlabs 1 or 2, their printers were not dental specific. They were actually 3D printers that were used in any industry, right? They'd print toys with them. They'd print parts for shoes with them. So they weren't actually dental specific. There were dental specific resins that were utilized, so you can use them in the mouth. More recently, they released, I think that they call it the Formlabs dental printer or something like that. So it's specific to dentistry. And that's just more the functionality, the user interface and things like that.
So have you gone up to Boston and seen this, or
we have a couple Formlabs 2 printers in our clinic, and then Carbon's taking the market again by storm when it comes to at least people talking about it and things like that. Because
which one?
Carbon, because of how fast it
CARBON.
is. Yeah, it's a really fast printer. Because Formlabs is affordable. I think you can purchase a Formlabs for $4,000, $5,000. A Carbon printer's closer to 100,000, so huge difference. But the main advantage of a Carbon is it's very, very precise, but it's also very fast. So what would take you around 4 to 5 hours to print using a Formlabs printer, you could probably do in less than an hour with a Carbon printer. So if you're a dental lab that's running a printer 24 hours, it makes a lot of sense for you to invest in a Carbon printer rather than a Formlabs printer.
So Formlabs is out of Germany. Where's Carbon Labs out of?
I'm actually not sure. It might be here. It might be in the U.S.
Is it U.S.?
Or Germany? I'm not sure.
Carbon is, let's see, it's wow, it's out of California.
Mm-hmm.
Wow, interesting. So you like that one?
Yeah, that's a very good printer. It's a very fast and accurate printer. It's only, like I said, obstacle was price point. It's very expensive.
And what are you printing?
You mean in terms of what we
is
materials
it,
or
yeah,
no?
I mean, is it surgical guides? Is it
surgical
temporaries?
guides, surgical guides, night guards, retainers. We can now print dentures. So whether those dentures are used as complete dentures or they're used for an implant an implant retained or implant supported restoration, we can print metal.
Now there's a big denture printer here. What is it? Avco?
Avident?
Avident.
Yeah.
So
they milled their dentures, I believe.
Oh, they're milling their
mill
dentures.
Their dentures.
They're
yeah.
not adding in.
Yeah.
Okay. So you're using a 3D Formlabs printer additive technique for surgical guides, temporaries, dentures.
Yep, we don't do them, not in our practice, but Carbon actually just very recently partnered with Dentsply to fabricate dentures. So Carbon prints, Dentsply utilizes their materials and technologies for the denture
That'd be
fabrication.
a classic example of something that's bleeding edge, not the time to buy and invest, and while they're working out all this high overhead stuff.
Yeah, no, not unless you're a lab. Like I said, if you're a lab that produces enough where it makes sense for you, like you'll pay it off just because of how fast it'll be compared to you running 3 or 4 other printers that are running much slower. So in terms of productivity, it does make sense. And Carbon's the printer I was telling you about that started the subscription or lease model. So again, they're trying to get rid of that obstacle.
So it's just a better model, and I'll give you some examples why. When out here in our backyard, there was a company called Smart Practice with Jim Naomi Road, and there was a lot of back in the day. There was a lot of software companies, and Prosthodontics was the only one where they came out and they said it's just $100 a month. And you remember when I got to school in '87, there were companies selling lasers for $50,000. One was that Nd:YAG laser for $50,000, and after they sold 1,000 at $50,000 a piece, they went bankrupt. And everybody was saying, "Well, how do you sell 1,000 boxes for $50,000 and go bankrupt? It's cash flow." They never knew what they were going to do, and all the other software companies, they were always adding programmers, laying off. It's always feast or famine. And when that Prosthodontics guy started, his name was Tom. He was up in Cottonwood or somewhere up there. He said, "Man, I just want $100 a month." He goes, "I'm up to 1,000 dentists. So I got 1,000 dentists give me $100 a month. And so you can budget everything. So when you're Netflix and you're Spotify and you know how much monthly revenue you got on, well, you can plan. In fact, that was the whole story of you remember the story of Procter and Gamble in the 1800s of how that became such a big company? You remember that one? People would go out on the ranch and they'd make just a boatload of soap and they'd load up their whole horse and buggy and they'd go through towns and they'd sell you this gunny sack of soap and you would buy the soap. Hell, you got a lifetime supply. And after they sold all that soap, they had no customers. And Procter and Gamble was watching these bankruptcies because, you got a statement of cash flow, which no one reads. You got a balance sheet, which you'll read when you get divorced. And then you have a profit and loss, which, when the mob wants paid every year, I love the American mob, the IRS. They say, it's time to pay taxes. You say, well, how much do I owe? I don't know. But if you get it wrong, you'll go to jail. Oh, that what a class act. And Procter and Gamble said, you know what we're going to do? We're going to reduce everything, bar soap, tube of toothpaste, everything, till you'll use it in a month because I pay my bills monthly. I pay my rent monthly. I pay my employees monthly. Rent, mortgage, equipment, build out, computer, engine. All your bills are paid monthly. So when they got it down to a monthly user, then they could go to the banks in Ohio and say, here's my monthly cash flow. And those banks would say, well, we'll loan you millions of dollars, and there was Procter and Gamble. And so these people that sell say a Formlab printer, how do you know what to sell it for? Because if you ever run a 90 or 120 day area with no sales, you're all gone. And I can tell you that nobody can predict the stock market, and anybody who says they can is complete crazy. But Richard and I remember 1980. We remember 1987 Black Monday. We remember March 2000, the Y2K bubble popped, and we remember Lehman's Day. So I've lived through 4 contractions. And every time there's a contraction, all these people that are selling high-end products, they go out of business. And the people that have the subscription revenue model, it works. So it's just a better model, and that's why at a time Netflix was almost worth more than Disney. Here's Disney with Disneyland, Disney World. They got, you've been to them. Your mom's been to, everybody's been to the Mickey Mouse Gardens. They got cruise ships and all that stuff. But, they'll release a big movie and they'll put $100 million in that movie and they're wanting $300 million back. But what if they release a $100 million movie and they only get $100 million back? So I think that anybody who's selling over anything for $50,000 to $100,000 should go to the subscription model. And I also think my kids. I don't know how old this smartphone is. My grandkids always ask me what kind it is, but no one's going to keep anything high tech for more than 5 years. So I would be much more inclined to buy any of this stuff if after 5 years I could call up Carestream and have an agreed upon, they'll pick it up and I'll give it. It's like every time I take my car in for an oil change, they always say, well, if you leave your car here and write me a check for this amount, you can have the brand new one. And so on. It's a better business model. So, okay, you said oral scanner, 3D, and now you're doing 3D printing.
3D printing and CT scanner if you're into implant dentistry, and then the other thing that I think really everyone can utilize, and you don't really need to invest much into this, is smile design. And again, if you're doing mostly day-to-day restorations, then maybe it's not right for you. But if you do any sort of cases that have a cosmetic component to them, whether it's dentures or whether it's, aesthetic dentistry, whether you're doing anterior crowns, starting to integrate virtual smile design into your practice is a huge game changer when it comes to communication with patients. And that can be as simple as taking a photograph, putting it on PowerPoint or Keynote, and having a pre-made template where you're able to overlay things and show them to your patient. So I always go back to the same 2 points: predictability, communication. That's what digital technology is allowing us to do. And for any newer dentist who is getting into things, you don't have to invest money into starting to utilize this technology. It's just learning how to utilize it. That's the thing, because it's a double-edged sword.
And so what are my homies most excited about at your DDI? It's dddental.com for Digital Dentistry Institute.com. First of all, the programs are all over the world, right? You don't have to go to Vancouver.
Yeah, no, we've got programs running in multiple cities in Canada. We've got them running in San Francisco, Houston, Atlanta. We're in Dubai. We're in the UK. We're in Malaysia. We're in India. We're in Australia. So
Moly.
yeah, and that's the real beauty of it all.
So it's basically 5 programs. It's okay. So you say core programs, digital programs, life surgery programs. What are your what's hot? I mean, what classes are filling out? What way? How, you're spreading around the world. It's either you're the hardest working man in dentistry, or you got a product that someone wants.
Yeah, so it's the implant programs are actually I think you had on your podcast Dr. Bobby Birdie and Dr. Sandeep Rawal.
Absolutely.
They're 2 of the 3 co-founders of the Digital Dentistry Institute, and I work with Bobby in Vancouver. We work together. So when they put this all together, they actually brought on board what was called the Pacific Institute for Pacific Institute of Implant Training or something like that. It was run by Dr. Ron Zokol for 25 years or so, where they provided implant training for dentists all across Canada and in some cases the US. And so our implant training programs have been around for a long time, and we all know what implant training programs are involved, right? You have the didactic component, you have the component where you're actually practicing on models or pig jaws or something.
Well, the didactic, that's just the reading and stuff.
Yeah, that's the lectures, the principles.
That's the one you should put online on Dental Town, because we put up 400 courses, and they've been viewed over 1 million times. I mean, that's crazy. Because you're, they just like to take an hour increment on their iPad, and then the hands-on things. But I think it'd be great marketing for you, and
No, absolutely. That's online education, something we're very excited about, and our plan is to 100% get into that, because it doesn't make sense in today's world for us to still be asking people to gather in a room to hear someone talk when they could be doing that from their office, from their couch, So we know that online education, it's a multi-billion-dollar business now, and it does better for people, right? It's better for people to be able to go at their own pace, to take that course from their own.
It's just better education, because I've seen a lot of this online research that's coming in. I mean, like little kids in the morning, they're sleepy. They're not even listening till like 10 o'clock. You're at a lecture, and you get texted or paged, or got to go to the bathroom, or you're hungry or sleepy. I mean, they have shorter attention spans than anybody wants to recognize. And at a 1 hour course, you can put it on hold. You can go do. So I think it's better delivery. It's faster. It's easier. It's higher quality. It's lower cost.
The challenge with online education when it comes to dentistry, though, is we run our programs usually in 3-day modules. On each day, we'll have a hands-on component where they get to take in the information and then actually apply it, even if it's on a model. And that makes a huge difference in how you retain that information. So what we're looking at is, how are we going to be able to utilize online education, but not give up on the hands-on component? So, that's where we look into things like virtual reality, or things where you're able to...
What did you think of the ADA changing their CERT program, where they're not going to give it to manufacturers? So Nova Biocare, if they sell an implant, you're not going to get, Have you aware of this change?
Do you mean they won't give it to corporate?
Have you seen that? Have you been hearing this?
I haven't seen that, but I understand that.
So if an implant company is running a CE program, they won't give them CE accreditation.
Right. That's what the talk is now.
Personally, I think that's a good idea, because I think what's lacking when it comes to education, and this more applies less to implant dentistry, more to digital dentistry, so much of the information that's provided on digital dentistry is coming from companies. I'd say 95% and more.
Oh my gosh!
Right?
I mean, it's crazy, because every time someone invites me to speak, they go, "Well, who are your sponsors?" No one. Well, what company will pay your honorarium? No one. And it's the same speakers at all these meetings, and I've been saying for 30 years, you got to dress them up as a NASCAR. I mean, I don't care if my favorite driver says Standard Oil or Pennzoil or whatever. Just come up there and wear your damn NASCAR uniform because it's called transparency, and they're not transparent. And these big meetings are it's crazy because when you try to manufacture, they say, oh man, we bought so much booth space, we got to pick 5 speakers. It's like, we'll say that on my show. Say it on the show. I mean, because the young kids don't realize. So, and then when you're as old as me and Richard, I mean, how many speakers can you name that would only mention this product for 5 years, and then on a dime they switch to another one. Then 5 years later it's a dime and another one. And I don't care what you're doing. I don't walk in your mouth, but it's called transparency. Just say it.
Yeah. And that's what I'm most excited about. What we're doing with DDI, we have, based on what I know, the only or the most comprehensive digital education program that exists in today's dental market. And it's the only one that I'm aware of that's as comprehensive as ours, where we cover everything from intraoral scanning to virtual smile design to 3D printing to CAD/CAM to milling to implant planning to 3D guided surgery. And all of it is education that's put together based on the actual fundamental evidence and science, rather than this is what the company says, these are the buttons that you should press on the laptop or computer. It's, why are we actually doing this? What are the different techniques that you can utilize, tips and tricks? Because if you talk to people who purchase a scanner or purchase certain software, a lot of them will end up putting it in a corner where it gathers dust. And that's because either they try to do their first case and it doesn't work out, and they're like, I'm going back to PVS, I know how to use that, and this doesn't work. But there's a learning curve. But second of all, they don't get the right education as to how to use that software or how to use that product. And that's what we're trying to change. It's how can you understand the fundamentals behind an intraoral scanner, so that whether you end up buying a 3Shape scanner or end up buying an iTero scanner, you're going to know how to use it because you understand the principles behind what it is that's happening.
So it's mostly implants. So I mean, Digital Dentistry Institute.
Our digital series of programs are broken up into modules, and some of those modules contain implants, so how to plan implants, guided surgery, whether it's single tooth, full arch. But then we also have modules that are unrelated to implants. So Digital A, as we call it, is focused on intraoral scanning, virtual smile design, 3D printing, and how to do CAD/CAM, so how to design restorations and send them to a lab, or design restorations and send them to a milling machine. And then we have our Digital D program that's purely focused on digital dentures. So how can you transition into digital dentures as opposed to your conventional 5-6 appointment traditional denture, which a lot of people don't want to do.
When I was your age, when I got out of school in '87, they told us dentures were this close to going to extinction.
Mm-hmm.
And here, 32 years later, the United States has more dentures in 2020 than they did in 1987.
Mm-hmm.
They're not going away, are they?
No, and we've got a course focused on digital dentures, nothing else, because of exactly what you're saying. They're not going anywhere, and digital technology is going to take away, in my opinion, which was the deterrent for dentists to fabricate dentures, which is, if you're running a clinic, in some aspects, you're also running a business, and fabricating dentures is very hard for you to justify the ROI, right? In terms of time, in terms of the complications and so on. But it's a service that a lot of people need more than anything else, right? Because when someone comes in needing dentures, that means that they need that service.
Well, it's the and I know we're out of time, but it's the biggest bait and switch thing in the world. I mean, when my buddies that do $4 or $5 million a year in implants, they all started. They moved into an area and they found the biggest brand name denture world, and sometimes it was in a little trailer in Apache Junction, but every elderly person knew you could go down there and they had a lab in-house and you could wait, and they would go get their diplomat in the International Congress Oral Implantology or the fellowship in the something, and they would come back and they buy that, and they advertise, and they still do it, like a complete set of dentures for $385. But then when you come in there, they say, okay, that's the standard. But Ivy Claire's got some prettier teeth, and that one's a couple hundred more, and then a couple hundred more, 2 implants, and a couple more, and they'll do they'll get 100 people in for that low cost fee denture, but they'll do an all-on 4 every week. And so it's just a matter of upgrading. You sell you advertise the low cost, and then when they come in, you upgrade them to more and more. And I know the guy did this in Bakersfield, here in my backyard, Florida, South Carolina. I mean, back in the day, that was the best business strategy to go. In fact, if I was a high-end prosthodontist like you in Vancouver, and there was just some low-income denture world or whatever, my God, I'd buy that in 3 seconds, because that's all the people. And that's also why Invisalign is taken off around the world so much, along with implants, because when you go to Malaysia, Vietnam, Cambodia, so many of these countries where the government is doing the Bernie Sanders socialized medicine thing, they don't have enough money to do the cleaning exams, x-rays. It's a big mill. But if they can upgrade one person in that big pool that they're breaking even to losing money doing below average dentistry, if they can upgrade one person to an Invisalign case a month, they're high end. Or one person to an implant. Like when you go to Japan and London and Tokyo, three of the Tokyo, London, and Paris, three of the greatest civilizations around, right? I mean, it's not as good as Copenhagen, where 3Shape is, or Helsinki, where Plan Mecca is. But I mean, right up there. The government socialized program gives you $100 US for a molar root canal. So, but they're polite people. They're not going to say anything in Tokyo. They'll tell you something drinking sake at the bar. But, they don't even diagnose a root canal. They said, well, that needs to be extracted, because when Bernie Sanders says that you can only do a root canal for $100, then they extract the tooth and they place a $1,500 implant and a $1,500 crown. I mean, hell, you're in Tokyo, where the land is $1 million a square meter. I mean, I did live podcasts from Tokyo, London about this question, and they were telling me, they go, dude, we're in Paris, France. You think we can do a molar root canal for $100 US? I mean, how out of your mind, how disconnected from reality are you? And that's why I'm scared about socialized medicine, because I only know dentistry. I don't know dermatology, and I don't know heart, lungs, livers, eyes, or whatever. But in my little narrow world, the socialized medicine plans for dentistry they're insane. I mean, I'm crazy. But anyway, so that's another reason why implants and clear aligners are both the only areas growing double digit, is because the insurance schemes, whether they be private or public, aren't fixing the price of that. But as soon as you go in there and fix wages, you'll get all this game theory. As soon as you go in there and fix apartment, rent freezes, like in Manhattan, those two do about every 20 years. They have to go back and stick their tongue in that light socket. They'll have to relearn these lessons the hard ways. But the only things growing in dentistry is where a third party doesn't set the limit. And I don't know why they do that. But so we went. Well, it was supposed to do an hour. We just passed an hour and a half. So what's your big close? And I'm telling them, I said, it's kind of tough, but if I was a young kid, $400,000 in debt, I don't like this Superman dentistry thing, because in 1900, healthcare was not even 1% of GDP, and there was no specialties. By the end of the century, it was 14% of GDP, and the physicians had 58 specialties, and dentists had 9. Now it's 2020. We're looking at healthcare 17% of the GDP, and when people say that it's too high and it's got to come back down, it's insane. Milton Friedman used to call it the little blue pill. Are you married with kids?
No.
Oh my God, are you a genius? How many grandkids are you up to?
7.
Oh my gosh. I don't know. I got some liquor under the table. But the bottom line, you go up to any grandma, grandpa, you go up to anybody in the world, and you see the little 3-year-old granddaughter, and you say, okay, she's got a horrible disease, and what would you give me? The little blue pill. She takes the little blue pill, she's fine. She doesn't take the little blue pill, she dies tonight. What would every grandpa, how much would they pay for that blue pill?
Whatever they have.
Yeah, would they give you their house?
Mm-hmm.
No one says we spend too much money on housing. No one's out there saying, oh, yeah, vote for me. We'll have nationalized housing. We're going to build big houses and you all live there. Every single mother says, take my house, my car, my cell phone, take anything I've got. to save my baby. And then you look at the cost, it's gone from 1% to 17% because it's the ultimate luxury item. The only wealth is health. Once you die, I don't care how many pounds of gold you have, I look for healthcare to pass a third of expenditure. I mean, imagine 1,000 years from now, when everything's made better. When you're born, you get great grandma's house, nothing wrong with it. Everything's solar, off the grid. Everything's high tech, and you don't have to do anything. And then you walk into the kitchen to go grab a beer, and your eyeball falls out. How much of that inherited wealth would you give back to get your eyeball back?
Yeah, health is above all when it comes to our
It's
priorities.
everything.
Yeah.
So it's the ultimate luxury item. It's like I love it that people are woke to the environment. The only people worried about clean air and clean water are rich people. During World War II, when you're worried about losing your country, I remember Jack Welch was sitting on the deal there saying, "Well, why did GE dump this in the river?" They're like, "Okay, first of all, it was during World War II." And we asked the president and the Pentagon, and nobody cared. What did they care about? They cared about Nazi Germany and Imperial Japan. No one cared about a river. And then 50 years later, with no wars and all that stuff, now it's a rich world problem to care about clean air and clean water and all that kind of stuff. But I think that healthcare is the ultimate luxury, and it's going to keep going higher and higher and higher and higher and higher because people are going to find out that what they really don't want to do is die. I mean, you'll seldom go to a funeral where the guy next to you says, "Look at that lucky guy. I wish I was in that pine box." I mean, 100 billion humans have died, and the 8 billion living humans know that they're in a better place than the 100 billion dead ones. And they're going to keep driving up the cost and the marginal gains. And the first people that caught on to that was the Mayo brothers, where you were from. The Mayo brothers couldn't figure it out because at that time, when your 80-year-old grandmother came in and she had cancer and everything, well, she's 80 years old. I mean, they didn't take her to the vet and put her down, but it's pretty much what they did. They're like, well, she's 80. And the Mayo brothers like, my God, they're willing to sell the family farm and pay whatever it costs to keep an 80-year-old lady alive. And that's where it's at. And my God, I would give both livers. I'm Irish, so I got at least 3. You do anything for your kids or your grandkids, and that's the way it's going to go. And anybody who sits there and says they're going to manage it, they're going to manage the care. Well, they're not business people. You talk to a business people, that mom will throw away her car, her house. In fact, what's amazing in downturns, they walk away from their home. The only thing you don't walk away from is their car payment and their phone. They're like, hey, give me my iPhone and my car, and I'll go drive away and live with my sister. So they'll walk away from a home. And when that baby's sick, they'll walk away from everything for that baby. So I recommend to the young kids that you can't do it all. I mean, if you think you're going to sit there and be master endo, pediatric dentistry, silver diamine, fluoride, implants, bone grafting, sinus lifts, while you're doing Invisalign and veneers and ortho tracings, this Superman doc stuff, there's no data for that. All the data shows in business from Adam Smith, a 32-year-old Scot who wrote in 1776 The Wealth of Nations, of specialization. And specialization has got us all this. I mean, everything you're talking about is not just dentistry, but just one part of dentistry. You probably don't know anything about making this microphone or this laptop computer or tiling a bathroom. So it's going to go to really high specialized. And I hear these kids saying, well, I want to learn endo and implants and Invisalign and silver diamine fluoride and veneers and cosmetics. And I'm okay, so basically, 10 specialties are a joke to you? I mean, would you want to go to a doctor who was doing 10 different specialties? So I think the easiest one to decide is it's going to be soft and pretty or blood and guts. And I like the blood and guts. I like the implants, the surgeries, the extractions. The people who make the most money are your oral surgeons and your periodontists and your implantologists. Orthodontists don't even make over 300. In fact, I'll show you the exact difference. And then the second thing is I would go into something where, your good buddy Bernie hasn't set the fee on that, because he'll set the fee, he'll get elected, and then he'll just ruin an entire industry. And that's fine. But I'll show you the numbers. Oral. Let me show you the difference between the 10 specialties.
I've seen that. Prosthodontics wasn't so good on that list.
Yeah, it's because the real wealth, I mean, is blood. So average oral maxillofacial surgeon 448, perio 330, endo 307, pediatric dentist 304. Once you drop below that, ortho 289, prosthodontist 219. And I feel sorry for you because we'll end it on this. The bottom line with prosthodontists is channel conflict. I have so many prosthodontists who are in that 219 area that say I can make 100 more, but if I start placing implants, then the periodontists and the oral surgeons are going to refer me cases. So they can't place implants. Same thing with endodontists. Endodontists want to start out saying, well, you know what, I think I'm halfway through this root canal. It's no good. That this retreat, the tooth's cracked. I'm just going to extract and place an implant. But they're looking over their shoulder thinking how many referrals are going to start. You know, they're making money doing implants. They're going to kill them. So are you surgically placing?
No, but we do surgically place in our practice. It's
and
just
who places them? Periodontists or oral surgeons?
Periodontists.
And who places them better, periodontists or oral surgeons?
Depends on your training. But I honestly think I think a restoratively trained dentist, or at least a dentist who understands the restorative aspects, will place implants better than anyone else, whether it's a surgeon or a periodontist or a prosthodontist.
Well, let me tell you the dark.
Prosthetically driven implant dentistry is always better than surgically driven implant dentistry.
Let me give you the dark history of when Brandemark came over here and started teaching implants. He would only teach them to oral surgeons.
Mm-hmm.
And a lot of my friends who own some of the biggest labs in the world listened to these lectures and decided they weren't going to restore implants at their lab because the oral surgeons were replacing them and they were pointing every which way. And they
where
said
the bone was, yeah.
Yeah, they said as a business decision, we're not going to do it. And it wasn't until periodontists started doing crown down techniques that your major labs, like Glidewell, when the oral surgeons were teaching implants, Jim Glidewell said, this is crazy. We're not even going to do it. So it wasn't until it was crowned down. By the way, you know, Brandmark's son is an orthopedic surgeon in San Fran. We need to get him on the show. What a legend! But so here's my advice. You got $400,000 of student loans because guys like Richard set up 7 dental schools. Are all of them $100,000 fees? Is that like your business model? You just set up a school and it's $100 a year.
I'm just a hired help.
It is a hired help. So it's $100 a year. So when you get out, you need to pick an area that's not someone else didn't set your price. And the people who want to set their price in healthcare, I mean, imagine if they would have done that for cars 30 years ago. We wouldn't even have airbags, anti-lock brakes, housing. I mean, if you want some low-hanging fruit, why don't you go do all that nationalized, socialized stuff? Why don't you do it to your house and your car? And by the way, you'll say, oh, well, my friends in Canada like it. Yeah, they like it because 99% of the population didn't spend the night in the hospital last year. Were you in the hospital last year for an overnight?
No.
Were you?
Yep.
And
more than once.
Yeah. So the bottom line, when 99% of the people don't spend the night in the hospital, how do they know better? But if you turn it around on them and say, well, if we manage your housing and your transportation and your cell phone and your clothing, any other thing, they wouldn't do it for a second. They'll do it for healthcare because it's not transparent. It's not opaque. It's very insane and crazy and all that kind of stuff. But any final words?
No, this was great. I think the only thing I'll add is your audience, like demographics wise, are they more starting off in their career, midway through their career, or?
I would, send me an email. Howard@dentaltown.com. Leave the comments in the YouTube. I love reading the comments in the YouTube, but about a quarter of them are still in dental school, and the rest are all under 30. And
the rest are all under 30.
Yeah. I mean,
Really?
I get one email a month that says, dude, I'm as old as you. All the other ones are, I graduated in, 2 years ago, 1 year ago, 3 years ago. And they, do you have Snapchat on your phone?
No.
Be honest, have you ever listened to a podcast?
No.
Yeah, my friends, if I put a gun to their head and said, pull up my podcast on iTunes, I'd have to shoot my own mom. No, nobody. In fact, I tell dentists when they, I half my friends still have an AOL email. nothing says erectile dysfunction like an AOL email. I mean, why don't you just, yeah, it's a young kid behavior. Snapchat, all that stuff, podcast.
So what I would say is we're on a verge in the dental profession where we are utilizing technology in a way that's not only going to make things more efficient. So what I always tell people is forget all the selling that you hear from companies that tell you it's going to be faster, it's going to be cheaper, it's going to allow you to take shortcuts. That's not, in my opinion, anything close to what the advantages of digital technology are. They're more going to allow us to more predictably treat our patients better and also be able to communicate with them better. So if we're on the start of this and you're a younger dentist, so you plan on practicing for another 15, 20, 30 years, it only makes sense for you to be involved in this transition rather than trying to catch up in 5 years. Because that's what happens all the time, right? And it's the same thing with technology. It's the same thing, except it's even harder with technology because of how fast it changes. But once you understand the fundamental principles of digital technology in dentistry today, it's going to be a lot easier for us to utilize that to better treat our patients. But then it's also going to be a lot easier for us to help advance it in a way where it's not driven by companies, but rather driven by healthcare providers to ultimately use this technology to better treat our patients. And that's something that I really care about, because do you believe in evidence-based dentistry? Right, we all as dentists believe in evidence-based dentistry. What I'll tell you is evidence-based dentistry is going to be thrown out the window when it comes to digital technology being implemented in dentistry, because there's no way our model of evidence-based dentistry can keep up with technology. Like you said, I called this an old phone and it's 2 years old. And in those 2 years, I probably upgraded it 6 times in terms of its software. And it's going to be the exact same things with any of the technologies we use to treat our patients. So if we're trying to make decisions based on the older model of how do I change the way I practice to treat my patients using systematic reviews and randomized control trials, we're going to be left behind. But at the same time, we can't have that transition go completely to what I read on a website or what someone who's trying to sell me a product tells me. So I think it's important for my generation of dentists to really educate yourself on these tools that you're going to be utilizing for the rest of your career in one form or another, and then make sure that you give your say as to how this technology should advance to ultimately better treat our patients and better our profession.
And tell them what you're doing in town with Richard. I assume it's some beer drinking contest.
So I call him Prof, because that's what we call them at the University of Sharjah. But Prof Richard is by far the person who has influenced my career as a dentist, but also myself as a person from anyone outside of my parents, because of how he's really instilled in us ethics and morals. And you're not dealing with it's not all about yourself, but it's more about giving back. So I'm just here to see him. There's nothing else, just to see him and spend time with him, because he's influenced my life in more ways than I can share. But he's really a great person, and anyone who knows him agrees.
Well,
I agree. I can vouch.
I've got to say, as an old teacher, how amazed it is to sit across the table from someone who graduated from dental school 5 years ago, and to hear what we've heard over the last 2 hours, which went probably an hour more than you were expecting. What a brilliant young man. This is the future of our profession, and I'm so happy to be a part of it.
Thank you. Let me tell you, I'm on social media. I have a lot of people who follow me, and if you're trying to communicate with people on social media, you want them to engage with you, right? So I put out stuff hoping that it'll interest them, add value to them, get their responses. The thing that I got the most responses from ever was adding to my story today. I'm going to Arizona to visit Prof Richard. Literally,
Nice.
Hundreds of people messaged me saying, "What? You're going to see him? Please say hi. Please say hi. Please tell him that we miss him." So it's.
Are you sure they were saying that, or were they saying is he high?
I mean, I also mentioned that I'm seeing you, so I don't know. Maybe they confused the two.
Oh, I doubt it.
Hey, no, I think that's so cool when teachers connect,
Yeah.
and my gosh, everybody who's a dentist can go back to just a couple of instructors.
Yeah.
Mine was in high school. It actually,
Yeah.
it's really neat when a teacher constructs, and a lot of people always say that the kids, millennials are like, well, they want to do something with purpose. It's like, dude, we all have the same purpose. In the last 50,000 years, 110 billion humans did their job and got us here in the present. And the only purpose you have is knowledge has no value if it's not transferable to your replacements. So every one of the 8 billion people alive today are going to be dead as the last 110 billion. And the only value is that we leave them a present. And I enjoyed being born when they had streets and electricity and all the things that made it amazing. And I never in a million years would have seen the cell phone coming, the internet, the laptop, the computer, and all that kind of stuff. But last night I had dinner with my mom, and my 4 boys have turned into 6 grandkids. I know you're at 7. I know I'm gonna call them up today, but. You look at those that my 1-year-old little Jasper. That's your purpose. Bottom line. And if you don't want to have a kid, it doesn't matter. The planet drops 300,000 newborn babies a day. 150,000 drop dead. 1 out of 3 don't even die of disease. Only 2 out of 3 people die of disease. The other 1/3 dies of accidents, car wrecks, war, violence, whatever. But I think the herd is amazing. I mean, look at Homo sapien. I mean, there's only like a dozen animals that ever lived over 100 years. Check that off. We're in there with the tortoise, the turtle, and a couple of fish. We're at 8 billion in number. I mean, in fact, when you look at just the mass, we're right in between like termites and beetles. I mean, sapien is doing good. When people say there's a healthcare crisis, like, okay, in 1800 there were 2 billion people. Now there's 8 billion people. Imagine going to a rancher and saying, there's 4 times as many cattle now in your pasture, and they're dropping 300,000 calves a day. I mean, we don't have a healthcare crisis. We don't have an opioid crisis. The opioid, that's the dumbest one I've heard. 324 million Americans, 50,000 died from opioids. When the British landed in Hong Kong, they said 1/3 of the whole country was stoned on opium. Well, I'm sorry, is 1/3 of Canada stoned on opium? Everything's exaggerated. We don't have a healthcare crisis. We don't have an opioid crisis. When you're part of a herd of cows that's dropping 300,000 newborn babies a day, I mean, name another species that can beat that. I mean, I think we're doing great. I think dentistry is doing great. It'll always be 2 steps forward, 1 step back. But when I go in those dental schools, or when we do some of these missionary trips where I've been in like Tanzania or Mexico, and you're sitting around with like 6 or 7 of these students, and they're all like him. They're all like good looking, smart, sharp, intense, ethical. And I always look at them and think, you guys are better than us. I mean, I go back to my dental school drinking buddies. I mean, yeah, I think this profession's in great shape, and you totally epitomize that. Thanks for joining our team, and thanks for replacing me and Richard someday.